Thank you for having me and for everyone in AAIP. So let's get started. Got a few slides to go through. So to start with some disclosures, I am going to be talking about, okay, we gotta get this going, sorry. Some of the different vaccines, one of which is made by Pfizer, and I purchased Pfizer stock about 8 years ago. So well before the pandemic. I did not predict this happening, obviously. So as far as objectives that we have, we're going to start with an intro into SARS-CoV-2. I'm going to talk a little bit about the virus itself and how it kills people. We'll talk about the importance of vaccination. We're going to talk about how the vaccines work. We'll talk about the mRNA vaccines. We'll talk about protein-based vaccines, and we'll talk about adenovirus, vector-based vaccines. We'll address some of the common myths associated with the vaccines and debunk them. And the last part is going to be dedicated to how pharmacists and technicians, such as yourself, can improve the outcome of the pandemic. So we're going to start with 3 questions for CME, and there will be a poll that Rosemary will be conducting. So question number 1, which of the following is true regarding the Moderna mRNA vaccine? It must be stored at -60 to 80 Celsius. B, it is only usable for 6 hours once at room temperature. C, if refrigerated, shelf life is 14 days. D, once the vial is opened, all 10 doses in the vial must be administered within 6 hours. It won't let me participate. I do. Okay. It's all over the place, so that's a good question. All right, next question. All right. Yeah, I gotta close the poll, sorry. Okay, question number 2. Which of the following is true for the Pfizer mRNA vaccine? It must be stored at -60 to 80 Celsius. B, maximum immune response is 4 weeks after the second dose. C, if refrigerated, shelf life is only 14 days. Or D, once a vial is opened, all 10 doses in the vial must be administered within 6 hours. And sorry for the typos. I have a feeling people will do better on this one. And they did. Okay, now the last one, I'm really going to throw you guys off. All right. Which of the following SARS-CoV-2 vaccines enters the nucleus of the cell? The Moderna mRNA vaccine, the Pfizer mRNA vaccine, AstraZeneca's modified adenovirus vaccine, Novavax, long vaccine name, modified spike protein vaccine, all of the above, or none of the above? Oh, yes! I totally won. Cool. All right. Oh, cool. You guys are going to learn some things. This is great. All right, so a little bit about me, because I probably know just a few of you. So my name is Dan Ketterer. I'm an infectious disease physician, board certified in infectious disease and internal medicine. In the outpatient setting, I focus primarily on LGBTQ plus healthcare, HIV issues, discrepancies in those populations and acquiring good health care. But I also do general infectious disease in the hospital as well. Originally from Chicago, I did undergrad at Georgia Tech, medical school at MCG, residency fellowship at University of Tennessee. I also do sketch comedy and have a YouTube channel called The Relaxing Sounds of Infection, where I do relaxing talks, kind of in an ASMR style, about infectious diseases. And you can find this presentation as well as other Grand Rounds talks I've given about coronavirus there, and information you can share with your friends and family. And at the end of the talk, I have some links for you guys to check it out. All right, so moving on to SARS-CoV-2, because it's also new in town. The John Mulaney reference, if you haven't seen this special, it's on Netflix and it's amazing. But SARS-CoV-2 really first popped up in Wuhan in December of 2019. It's a single-stranded RNA virus, plus sense, one of the largest in the beta coronavirus family. It's one of 7 human coronaviruses. The other ones that you probably are familiar with are the SARS-CoV-1, which was responsible for the 2003-2004 SARS outbreak, MERS-CoV, and then the other 4 are long strings of letters and numbers that primarily cause upper respiratory infections in children. So the 4 important structural proteins of SARS-CoV-2 are spike, envelope, membrane, and nucleocapsid, which goes under the wonderful acronym of SEMEN. Spike protein binds to the ACE2 receptors. Those are the target cells, which allows it to enter in. And where ACE2 receptors are found, they're found primarily in the type 2 pneumocytes in the lungs, but also in the GI tract. They're in the central nervous system, the heart, kidneys, and liver, which is why COVID-19 can have such a broad presentation, as we'll talk about. Some of the non-structural proteins are also important with coronavirus, and emphasizes the importance of why we need to vaccinate everyone, is that SARS-CoV-2 actively downregulates parts of the immune system that would allow its recognition and upregulates pro-inflammatory cytokines, which is part of the reason we see the cytokine storm in some individuals. And this is also very important. Neutralizing antibodies are primarily against the spike protein, which blocks the virus from entering cells and replicating. But the T cells can also recognize these other structural proteins. So how SARS-CoV-2 kills people. So if we're talking about the lungs, which we often think of this as a respiratory disease, so the virus attaches to the ACE2 receptor on type 2 pneumocytes. Now, these are the lung cells that produce surfactant, and surfactant is a lubricant for the alveoli that allows the alveoli to expand and collapse. And so it's very, very important in providing oxygenation. So the immune response that's generated to the virus ends up causing vasodilation and leaking of fluid into the alveolar spaces, which decreases gas exchange and causes hypoxia. Over time, you will get granulocytes migrating into the area that release inflammatory cytokines that also do collective damage to the surrounding type 1 pneumocytes. This will lead to what's known as acute respiratory distress syndrome, or ARDS, and lung fibrosis over time and scarring. The viruses I talked about earlier also, in an attempt to keep itself alive longer, actually changes the immune response into what's called a Th2 pathway, which is a primarily cytokine-driven response, rather than a Th1 pathway, which is a recruitment of T helper cells and B cell activation, which produces antibodies. So because you're getting this upregulation in cytokine production, you also see over time DVT formation, pulmonary embolisms, MIs, and strokes. So, as I talked about before, it also infects other ACE2 receptor-containing cells, which are found in the GI tract, kidneys, liver, CNS, and conjunctiva, which is why some people also present with GI symptoms as their primary symptom, like diarrhea. A very quick nitpick about SARS-CoV-2 and COVID-19. COVID-19 actually describes the constellation of symptoms that you get from coronavirus, SARS-CoV-2, not the actual virus. So as I put up here, AIDS is the constellation of symptoms that you get from essentially unchecked HIV. So you can't, when people say, I caught COVID, you really can't catch COVID and you can't vaccinate against COVID, yet despite this, it's called the COVID vaccine. So we're going to be talking about severe COVID-19 quite a bit, so I needed to put the definition up here so you guys understand what severe COVID is. These are typically patients that are going to be in the hospital. So meaning severe COVID is someone who is setting less than 94% on room air, they need supplemental oxygen, or they may be on a ventilator or ECMO. So how do the mRNA vaccines work? So one of the concerns a lot of the public has is that this is a relatively new vaccine, and many people believe it has been untested, and that could not be further from the truth. The research into mRNA vaccines has been going on for over a decade. It was initially being developed for gene therapy applications and chemotherapy applications. The issue with mRNA vaccines has always been a few different things. In those applications, they require repeated doses and higher doses, so side effects were an issue. And recently, the stability problem of mRNA vaccines was worked out. And the stability issue is when mRNA is injected into someone, it's rapidly recognized and broken down very quickly. The revelation in allowing the vaccine to work was a few different things, which was creating a lipid envelope for the mRNA to encapsulate it, but also the processing. So true to and how mRNA is formed in the body, it does have a 5' and 3' untranslated region, a 5' cap, a poly-A tail, and they also modified the nucleosides to help increase its in vivo stability. So, important thing about the vaccine, people think that the mRNA vaccines alter your DNA or incorporate into the nucleus, and neither of these things are true. Once the vaccine, which is in this lipid nanoparticle envelope, fuses with the cell, the mRNA is delivered to the ribosomes, and the ribosomes are actually outside of the nucleus. The mRNA in the vaccine never enters the nucleus, so there is no chance for the vaccine to alter your DNA. So once it is translated by the ribosomes, the mRNA in the vaccine is rapidly degraded, and it's translated into the full spike protein of the SARS-CoV-2 virus, specifically in its pre-fusion binding conformation. So the spike protein is a dimer when you look at the 3D models of it, and it changes conformation. It's sort of like a key and a lock, but the key is modified once it is activated into the lock, so the actual protein changes somewhat. So by having it in the pre-binding conformation, antibodies are able to target the virus before it fuses with the cell. So you need it in the pre-binding conformation. The vaccine doesn't have cellular tropism. I put that in here because that's one of the things that's still kind of in the back of my mind, is that the virus itself has cellular tropism to ACE2 containing cells, but the vaccine can technically make the protein in lots of different cell types, which is both a good thing, and then also it sort of makes me wonder, you know, is there an issue of potential autoimmunity with the vaccine? Fortunately, that hasn't been seen in any of the clinical trials. And as I mentioned, it doesn't enter the nucleus of the cell. So this part gets a little complicated, but I think it's really, really essential to understand how this vaccine works, because it is very novel and a really unique way of producing a vaccine. And once you understand this, when people tell you the vaccine was rushed or it wasn't ready and delivered too early, if you can show them the beauty of the engineering that went into this vaccine and just how well thought out it was. Once you understand that, I think you can help convince people to get the vaccine. So keep in mind, we had the sequence of this virus on January 10th, 2020, and the first doses of the mRNA vaccine that we have available today from Moderna were injected into human participants in March of 2020. And it was able to be constructed so quickly because the platform already existed and it had been developed over the course of a decade. Once you have the platform, it's a matter of having the templates, which was the sequence of SARS-CoV-2, which was released globally on January 10th. Literally, the work started immediately because of the urgency of the problem, and because we're building on existing research, it was able to be made in such a quick manner. But at the same time, because it was able to be developed so quickly, it allowed time for it to go through the standard 3 phases of vaccine release. And we're now in phase 4, at least for the mRNA vaccines, now that they have been widely distributed. So again, how do they work? So I have a graphic on the next slide that helps illustrate this a little bit better. It's a bit complicated, so you may have to go back later and rewatch this portion. But what happens is, once the spike protein is made via the ribosomes, one of 2 things can happen, and they activate different pathways. One is what's called the MHC, major histocompatibility complex 1 pathway. Now, what MHC1 is proteins inside your cell are constantly being broken down by things called proteasomes. This has multiple applications. If you have a cancer within your cell, or your cell is cancerous, it's forming abnormal proteins, which will then get broken down by the proteasomes and put onto MHC1. That MHC1 receptor is recognized by CD8 T cells, or cytotoxic T cells. And what it's looking for is the protein that's in the MHC receptor a self protein? Is this a normal cell protein or not? Keep in mind that viruses are foreign proteins, essentially, or they produce foreign proteins. So this pathway is very essential in virus recognition once it's already inside the cell. Because remember, antibodies do not get intracellular. So the MHC1 pathway is how a cell recognizes non-self or cancer-infected cells or virus-infected cells. So once it's producing this spike protein, some of it is broken down and put into MHC1. This activates the CD8 T cell pathway of immunity. The CD8 T cells then inject signals into the cell that cause the DNA to break down and the cells to undergo something called apoptosis. So that's one method in which the vaccine works. The second method in which the vaccine works is some of the spike protein is externalized outside of the cell and either put onto the cell membrane or put into their own little micelles and externalized. And these proteins are then picked up by what's called antigen-presenting cells, or APCs, such as dendritic cells or macrophages. These then will activate, so the antigen is then broken down and put on a separate receptor called the MHC2 receptor. That is then read by CD4 T cells, or helper T cells, which then present that antigen to naive B cells. And the B cells then undergo differentiation and maturation. And in that maturation process, they work to become a better fit for the antigen. So the antibody on their surface, the B cells then go to the lymph nodes and then have point mutations that occur until they have a really good fit for that antigen, in this case, the spike protein. So it takes time to produce the correct antibody, the correct key for the lock, which is why vaccination is so important and why the maximum protection from the vaccine happens several weeks into the process. This isn't an instantaneous thing. So that's the CD4 T-cell, B-cell pathway. Your end result is, to the vaccine, is you form these special type of memory cells. One are memory CD8 cytotoxic cells, which will then, once exposed to the virus again, these will rapidly divide again, and they're responsible for destroying cells already infected with SARS-CoV-2. You also develop something called long-lived plasma cells. These plasma cells are the ones that produce antibodies and will keep antibodies at a high level, even when non-infected. And they can last for years. And the third important types of cells that you develop are memory B cells, which can then, when re-exposed to the virus, generate more antibodies and more long-lived plasma cells. So here's a diagram. Everything I just said is in this diagram. Screen grab this slide. So you can see the two different ways that this works. The mRNA vaccine produces the spike proteins. Part of it is put onto MHC1 in the non-antigen presenting cells that tells the cytotoxic T cells here, hey, kill this cell, it's infected with virus. That's the class 1 pathway. And then the second pathway is for the antigen presenting cells, like dendritic cells. After it's externalized, it picks it up, it puts it on this MHC2. That activates the CD4 T cells, which then activate the cascade of signaling and cytokines that triggers B cells, plasma cells, and eventually a lot of the symptoms that people describe when they get the vaccine, and immunological memory. All right, so now that we kind of understand how this works, you understand why side effects happen. Because those cells that are producing the spike protein that have MHC1 get destroyed, which is why you get arm pain and local swelling with this vaccine at a fairly high rate. So everything we talked about here, we've already discussed. One thing I didn't mention because it's already complicated enough, the vaccine also helps activate the innate system, the sort of dumb, although there is no dumb part of the immune system, which includes natural killer cells, macrophages, and granulocytes. It migrates more to that area, but the memory aspect of the vaccine is the most important part. So now that you understand that, you can address some of the myths. The vaccine doesn't incorporate into the nucleus. It doesn't interfere with our DNA. It doesn't actually generate infectious coronavirus. It's only the spike protein. There's no other part of the virus. It does not cause COVID-19, and it's not self-replicating. Once it's used by the ribosome, the mRNA in the vaccine is broken down. So we're going to go to the next category of vaccines. These are not available in the United States right now, but they are being mass-produced for the UK and Mexico and a few other countries, which are the adenovirus vector vaccines, and they're a little bit different. So the two big players in the space right now are the AstraZeneca vaccine and the Janssen or Johnson & Johnson vaccine. Now, they do use different adenoviruses. The AstraZeneca vaccine uses a non-replicating chimpanzee adenovirus, and the Janssen or Johnson & Johnson vaccine uses a human adenovirus that is non-replicating. And the idea behind using a chimpanzee adenovirus is that we wouldn't have an immune response to it, because hopefully we didn't get chimpanzee adenovirus beforehand. So this is a DNA virus. What happens and how this differs from the mRNA virus is that because it's a DNA virus, it does actually get into the nucleus of the cell, where it is translated into mRNA. That mRNA is then taken outside of the nucleus, and then from here on out, it's exactly the same as the mRNA vaccine. So that mRNA that's taken outside of the nucleus is then translated into the full unmodified spike protein. And then the mechanism of action is exactly the same as the other mRNA vaccines. Now, one of the advantages of the adenovirus vaccine is its long shelf life and the fact that it doesn't need to be kept in deep cold storage. So part of the market for the Janssen and the AstraZeneca vaccine is the fact that it can be refrigerated for up to 6 months. Additionally, the Janssen vaccine, as we'll talk about, is being investigated as a single-dose vaccine. So some of the myths regarding the adenovirus vaccine, again, it doesn't actually incorporate into our DNA. And I think that's really important once these vaccines are available in the United States, that we inform folks, look, it does enter the nucleus, but it doesn't alter the DNA in any way. The virus is also non-replicating, so this is a non-replicating vaccine. Many people are worried that, okay, if I inject myself with this virus, the virus is then going to replicate out of control. But with these vaccines, the virus is non-replicatable. And again, does not cause COVID-19. So moving on to our third vaccine type is the protein-based vaccines, or the Novavax is the name of the manufacturer for these protein-based vaccines. So this one's currently in phase 3 trials. The results of the phase 3 trials are expected to come at the end of this month. What's available for us right now is we have the phase 2 data. So how this vaccine is made is also really interesting. This is actually how Flublok is made, which is they use a baculovirus, which is a insect tropic virus, to infect moth cells in culture and make them into protein factories, so that these moth cells in culture are producing massive amounts of spike protein. So this is how they make egg-free vaccines for influenza. Then those spike proteins are assembled into nanoparticles, and what makes these vaccines also different is that they use an adjuvant to help bolster the immune response. Now, what's important about this particular vaccine as well is that it doesn't utilize that intracellular pathway that we talked about with the mRNA vaccines, the MHC1 pathway. But there is another way you can activate that pathway through antigen-presenting cells, activating CD8 cytotoxic T cells directly. Another thing I have at the bottom here is the phase 3 trials, like the mRNA vaccines, is not expressively looking at asymptomatic individuals. Moderna did collect some data on asymptomatic individuals, but their definition for vaccine failure is someone who tests positive for SARS-CoV-2 and has symptoms. So if you know about this virus and what is expected to be fairly high prevalence of asymptomatic infections, with upwards of almost 50% of them being asymptomatic, you can see why the 95% quoted efficacy may actually be much lower. So here's a diagram of how the Novavax works. These nanoparticles are taken up by antigen-presenting cells like dendritic cells, which then breaks them down, presents them to the helper T cells. The helper T cells go off and activate B cells and CD8 cytotoxic T cells. All right, let's talk a little bit about the efficacy of some of these vaccines. So the Moderna vaccine, over 30,000 participants in the phase 3 trials. So they were followed 7 weeks. It was a 1-to-1 placebo versus vaccine, and the endpoint, as we discussed, was both RT-PCR positivity and symptoms over 14 days after the second injection, which is why they say your maximum protection with the vaccine comes 2 weeks after your second injection. So important, in the Moderna group, there were 0 cases of people with severe COVID who got the vaccine versus 11 in the placebo arm, and 11 cases of COVID in the vaccine arm versus 185 in the placebo arm. So overall, 95% efficacy. So Moderna did collect some data on asymptomatic individuals. They just haven't fully released it yet. So overall, it looks pretty good. So in the asymptomatic group, so these were people who later tested positive but had no symptoms, 38 were in the placebo group, and 14 in the vaccine group when they unblinded it. The vaccine efficacy was better in folks under 65, and the Moderna vaccine is indicated for folks that are over the age of 18 versus Pfizer's 16. So moving on to the Pfizer trial, it had more participants, 43,448, similarly run 1-to-1 placebo versus vaccine. Pfizer did include some folks with immunocompromise, such as well-controlled HIV, but like Moderna, excluded pregnancy and severely immunocompromised patients, as well as patients who had prior COVID-19. And we're going to go into detail on that on a later slide. So by the time that the vaccine was released in the United States in late December, we already had 2-month data on quite a few of the participants, and the efficacy across all subgroups was between 90 and 100%, which is also excellent, averaged about 95% again. And there was 1 severe disease in the vaccine group versus 9 in the placebo arm. So, as I alluded to, the vaccine efficacy may be less than 95% because of the fact that they weren't really looking for asymptomatic individuals, and we still don't know how well the vaccine protects in asymptomatic cases. And asymptomatic infections is a primary driver of SARS-CoV-2 infections, and why we have such a difficult time controlling the pandemic is people who don't have symptoms that are still spreading the virus. And the long-term efficacy is still unknown, but in talking with folks that are in the vaccine world, they estimate the duration of this vaccine to be at least 1 year. So the adenovirus vaccine trials were a little bit different. In their placebo arm, their first dose that they gave was actually meningococcal vaccine, and the reason for this is they wanted to create some immune response, a vaccine-dependent immune response. They actually wanted to make it harder for their vaccine to be successful or tease out the effect. So I do commend them on this. Their phase 3 trial had 12,000 participants, which were divided up between Brazil and the UK. Again, a 1-to-1 placebo versus vaccine. I put placebo in quotes because the first dose was meningococcal vaccine. But if you are familiar with this, they actually messed up the trial and gave the UK folks a half dose of the vaccine as the first dose and a full dose of the vaccine as the second dose 4 weeks later, versus the participants in Brazil got the full dose of the vaccine that were in the study, that were in the vaccine arm both times. And oddly, the folks in the UK who got the half dose and followed by the full dose did better. The reasons for this are never given. Part of it could be the variants of the virus or the demographics of the population. It's not really known. So failure was defined as a positive PCR regardless of symptoms, and there were no cases of severe COVID in the adenovirus group. So the J&J vaccine, the Janssen vaccine, again, like I mentioned, it's being studied in 1 and 2 dose intervals. The phase 1 and 2 data is out. The phase 3 data is coming at the end of the month. So in the phase 2 data, which had 805 people in it, 90% of people had neutralizing antibodies by day 29 and 100 by day 57. They're also looking at different cohorts based on age and 2-dose versus single dose and a low and a high dose. So lots of different groups that they're investigating. So the Ensemble trial, which will be coming out later this month, has over 60,000 participants in their phase 3 trial. So a very robust data set. So let's talk a little bit about some of the side effects from getting the vaccine. So with the Moderna vaccine, over 90% of people had injection site pain, fatigue, headache, muscle pain, rigors. Lymphadenopathy is not something I've seen from anyone who's gotten the vaccine so far, but over 1 in 5 people had it in their trial. Some important caveats are that older people are less likely to get side effects, so those over the age of 65, and the side effects in both trials were worse on the second injections. But importantly, there were no anaphylaxis or severe allergic events in the Moderna phase 3 trial, and there's no evidence of something called antibody-dependent enhancement. And just really quickly about this, this is something that is seen with the dengue vaccine, where the antibodies that you generate actually do not neutralize the virus, but help the virus infect the macrophages that come to eat them. So antibody-dependent enhancement is a very bad thing, which is not seen with this vaccine. So the Pfizer vaccine had very similar side effects. Injection site pain being more commonly seen in people who were younger, fatigue, headache, and fever. I personally have had both doses of the Pfizer vaccine at this point. After my first dose, I had injection site pain for 24 hours. After the second dose, I had worse injection site pain and then headache and fatigue for 24 hours. So most of these side effects lasted between 24 and 48 hours and were improved with ibuprofen or acetaminophen. Again, no anaphylaxis or severe allergic events in these groups. So in the adenovirus vaccine, some of the side effects seen, again, very similar: fatigue, headaches, muscle aches, fever. Now, one important caveat is both the Janssen and AstraZeneca trials had to be paused due to a single severe adverse event, and details of what this adverse event is are very difficult to find. But I think it's important to point out that both of the adenovirus vaccine trials have had to have pauses due to a single participant having a severe event. So one of the questions I get asked all the time is, so some of these side effects of the vaccines mirror COVID-19. How do I know if what I'm feeling is related to the vaccine, or did I get infected with COVID-19 after I got the vaccine? So there's a couple ways you can differentiate them. So some of the symptoms overlap. Obviously fever, muscle aches, fatigue, but injection site reaction, so if the pain is primarily at the site of injection, that's more seen with the vaccine than with COVID-19. And then some of the symptoms that are specific for COVID-19, especially things like anosmia, the inability to smell, ageusia, which is the inability to taste, cough, and sore throat are much more commonly seen with COVID-19 or SARS-CoV-2 infection. The other thing to keep in mind is that the vaccine side effects usually wane within 24 to 48 hours. So because I'm talking to pharmacists, I need to address the acetaminophen NSAID before vaccine controversy. So CDC does not recommend taking acetaminophen or NSAIDs prophylactically before vaccination, as it blunts the immune response. So I did a little deep diving into this topic. A lot of the speculation about this comes from data in children, where they pre-medicated children, and it seemed to blunt some of the immune response and antibody formation, resulting in lower titers. But a lot of questions are surrounding this. One, some studies actually show acetaminophen improves immunogenicity of influenza vaccine in the elderly. Also, it seems to only affect the first dose of the vaccine. And is the reduction in antibody formation actually change the protection? That is another question that's not really well known. So because it's not well known, and the easier answer is just to say, don't take NSAIDs or acetaminophen, and I agree with that position. If you can keep people from using them beforehand, that is recommended. But let's talk about some medications that likely will blunt the vaccine response. So high-dose corticosteroids, T-cell proliferation inhibitors like calcineurin inhibitors, transplant medications like antithymocyte globulin, cyclosporin, B-cell inhibitors, so patients who have RA, if they can come off of these medications, or if they have a holiday where they're not getting it, that may be the time you want to vaccinate them, or folks who are on chemo regimens. So also important to point out groups that were not included in the Moderna Pfizer vaccine trials, pregnant patients being the biggest one, although this is fairly typical to exclude immunosuppressed and pregnant patients from clinical trials. ACOG does recommend that pregnant patients get the coronavirus vaccine, as they are at a higher risk of developing severe COVID. So also not included were people getting other vaccinations at the same time as their coronavirus vaccine. CDC recommends waiting 14 days between vaccination or getting any other types of vaccines. They also didn't include people who already had SARS-CoV-2, which is a frequently asked question I get, is I already had COVID-19, should I get the vaccine? Now, the number that was being thrown around initially was 3 months for antibody protection after COVID-19. I recently attended a CDC IDSA webinar where they were saying that number is going to be revised to 6 months. However, that duration of antibodies is dependent on gender and age and other medical comorbidities. With younger females without medical comorbidities having the longest and typically highest amounts of antibodies. They also didn't study people who had gotten Regeneron or bamlanivimab, the monoclonal antibodies for COVID-19, before they got vaccinated. And severely immunocompromised individuals were excluded, but as I mentioned before, they did include some folks who had stable HIV. I would vaccinate the individuals that are severely immunocompromised if you can, as they are some of the highest risk groups of having severe COVID and dying. So let's talk about differences between the Moderna and Pfizer vaccines, which was some of the questions that we had in the beginning. So the Pfizer vaccine, as you know, has a strict cold chain requirement. It's shipped in dry ice containers to help keep that. It's not recommended to actually open these containers more than for 3 minutes twice a day. So you can store them at negative, so they can be stored for 30 days at negative 60 to 80. Outside of cold storage, it's 5-day shelf life in the refrigerator. You have to dilute it with saline, and then once it's diluted, it has to be used within 6 hours. There's also 6 doses per vial. So when you're taking vials out of storage, you have to make sure you have the correct number of people to be vaccinated, so you don't waste them. The second dose is administered 3 weeks after the first, and maximum immunity in the studies was 7 days after the second dose. So with the Moderna vaccine, it's a little bit more flexible as far as the cold chain goes. It can be stored between negative 25 and 15 Celsius and then refrigerated up to 30 days if unopened. So a very important difference between the Moderna and Pfizer vaccine is their multi-use vials have more doses in them. So each Moderna vaccine vial has 10 doses, and once the first dose is given, you have 6 hours to give those remaining 9 doses. One way to get around this is have a sort of waiting list for interested individuals in the community. I actually talked to someone in California who was not part of the medical community but was able to get the vaccine because extra doses or doses that had already been opened when they were vaccinating in LTAC, they opened up to the general public some of those doses. The second dose of the Moderna vaccine is given 4 weeks after the first, and immunity is 2 weeks after the second dose. So how do you test for coronavirus after someone's vaccinated? It's a question I get frequently. They're like, well, if you're producing the spike protein, won't you test positive? And the answer is no. So the PCR testing that we use actually targets the nucleocapsid protein that we talked about before. Some of them also look at RNA-dependent RNA polymerase. The antigen testing, again, also is looking for nucleocapsid protein, which is not something that's produced by the vaccines. So with antibody testing, this is a very important caveat, is that there's different antibody tests that are available. Some of them are looking for total antibody, which is a mix of nucleocapsid antibody, spike antibody. You want to get a antibody test that differentiates out the antibodies, because a vaccinated person will not have nucleocapsid antibodies. So you can make the differentiation if someone had already been infected or was infected after vaccination by looking for the presence of nucleocapsid antibodies. So if people are getting side effects with the vaccines, how do we vaccinate healthcare workers and essential frontline workers effectively without losing too many of them to side effects at the same time? And one of the ways you do that is that you rotate the groups. So having, for example, in a nursing unit, in your ICU unit, vaccinating people before they have time off, like on a Friday, if they're off for the weekend, would probably be the best way to address it, or vaccinating in a rolling vaccine schedule where you vaccinate certain members of the staff at given times so that you don't have everyone out at the same time with fatigue or headache from the vaccine. And remember that the second dose of the vaccine, especially in younger individuals, tends to have more side effects. Another important question is, will it work against some of the new variants that have been making the rounds in the press, namely the B.1.1.7, aka the UK variant of the virus? So a very important thing that isn't discussed much is that this virus doesn't seem to mutate at the rate that influenza does. So influenza has very, very, very frequent mutations, or what we call antigenic drift and shift. SARS-CoV-2 mutates, but it typically will only change a couple amino acids. So the B.1.1.7 variant has some mutations in the the RBD region, the receptor binding domain of the spike protein, that may make it more likely to be transmitted, but as far as at this point, does not seem to actually alter the course of the disease. And this is very important when people are panicking about these variants, is that all variants of SARS-CoV-2 are highly infectious. And these variants are seen throughout the world. There is not just one or two variants, but it's dependent on geographical distribution. There's numerous circulating variants. So will the vaccine work against the variants? And this is a big question, and I give my prediction, but my prediction is not proof. The vaccine targets multiple different epitopes or antibodies target multiple different epitopes of the spike protein, so just changing one of them will likely not change the efficacy of the vaccine. So my theory is that the mRNA vaccines will work very well against the variants. One of the possible downsides of the variants is that monoclonal antibodies, on the other hand, have less of a tolerance against point mutations. So it may affect medications like Regeneron or bamlanivimab. So should those who have had COVID-19 get the vaccine? My answer to this is yes, if it's available to them. So like we talked about before, if you've had COVID-19, you can reliably expect to have antibodies between, I would say, at least 3 months. Now, there have been reinfections, and I think that's an important thing to discuss. There have been a handful of people who have gotten reinfected, and we know that they were reinfected because they had typing of their viruses both times. So they had distinct COVID-19 twice. And keep in mind also, many people don't have symptoms with this virus. So there's a large pool of asymptomatic individuals. So it's oftentimes very difficult to tell when you actually got COVID-19 so that you can safely calculate out that 3 or 6 months. So why vaccinate people that have already had it? One, the vaccine response is much more predictable than actually getting the virus, obviously. So like we talked about, the virus, in an attempt to stave off the immune system, produces these inflammatory cytokines and triggers this pathway that leads to inflammation and clot formation. And there's also something called long COVID, which I don't really go into on this, which may be more of a cytokine and autoantibody formation. The vaccine, by vaccinating people, you're helping prevent autoantibody formation through natural infection. So it promotes predictable immunity that's also expected to last a very long period of time. Another question I got, and I got this question today from a physician who got COVID-19 after getting the first dose of their vaccine, was, when should I get my second dose? And that is, the second dose should be administered once the individual is no longer symptomatic. So very briefly into the vaccine allocation plan. We're already past part of this. The Georgia plan is mirroring the AAIP recommendations, which is the CDC subcommittee, the advisory committee on immunization practices. Phase 1A, which was essential healthcare workers and LTAC residents, is already well underway. Georgia's plan mirrors this. A couple interesting caveats about the Georgia plan is that they are tracking vaccine utilization through GRITS, one of my favorite systems, and they're using the GRITS system to determine where vaccines need to be distributed. They're also, one of my concerns was, are they making sure to allocate for second doses in case there's a shortage? And the answer is yes. So the next step is going to be drive-through vaccination centers. Fulton County is already setting up for this and potentially putting the vaccine in pharmacies in phase 2 of vaccine distribution. So briefly, phase 1B is non-medical frontline essential workers like postal workers, firefighters, police, grocery store folks, teachers, and persons over 75. 1C is going to be people between 65 and 74 and people with medical comorbidities that put them at a higher risk of severe COVID-19. And phase 2 is anyone over the age of 16 that's not in phase 1. So should I get the vaccine as soon as it's offered to me? Yes. So the caveats to this is, if you're currently infected with SARS-CoV-2, if you're allergic to a component of the vaccine, that's very important that it is not allergic to any vaccine, but specifically to the components in the mRNA vaccines. Also, if active immune suppression can be temporarily lifted, I would recommend that. So how can you, as a pharmacist or a tech, help improve the outcome of the pandemic? So I cannot stress this enough. As a medical professional, people in your friends and family circle are looking at your decision as far as, do you personally take the vaccine or not, into their decision to get the vaccine. Which is why when I got the vaccine, I made sure to get it the first week it was available and then video it. Video the actual administration of it to show people it's not a very long process. It is not painful. If you can do this and take a photo and share it with your friends and talk with them about the vaccine, talk with your friends and family, talk with essential and frontline healthcare workers that you may encounter on a daily basis when you go to the grocery store, for example. If they're going to get the vaccine, help address some of the questions. Help debunk some of the myths with some of the information that you learned today. And also you can help promote other things that help the pandemic, like mask wearing and social distancing for people that aren't doing it. You can also donate blood or encourage others to donate blood or convalescent plasma, and then check in with folks who are elderly or potentially isolated to check in on their mental health, because they have been isolated since the beginning of lockdowns in March. So moving on, continue to promote evidence-based treatments for COVID-19. So this is something that you can do in the hospital. So stand up against physicians that are using unproven treatments like ivermectin, vitamin C, vitamin D, zinc, melatonin, and probiotics for COVID-19. And work with your ID folks. If you feel like you don't want to directly confront the individuals who are ordering some of these medications, we will be happy to work with you from a stewardship angle. It's also important to continue addressing antibiotic stewardship in COVID patients. Oftentimes they get the kitchen sink dumped on them when that's not entirely necessary. Bacterial superinfections with COVID-19 are not as common as you would see with something like influenza and Staph aureus superinfections. So having empiric antibiotics to cover bacterial pneumonia when someone clearly has a radiological pattern that is ARDS from COVID-19 is not necessary. So as a pharmacist or a clinical pharmacist, talking with those physicians, especially the frequent offenders that are doing these things, and working with your ID colleagues, we are more than happy to help you with this. All right, let's go back to those initial questions that we had. So question for CME number 1, I think this was about 55% of you got this correct. The Moderna mRNA vaccine, remember, is a 10-dose vial, and they have to be used within 6 hours. You guys all nailed the Pfizer mRNA vaccine one about the cold chain requirement. And then question number 3 was the one that got you guys. So the AstraZeneca modified adenovirus vaccine does enter the nucleus. All right, last slide. So this is my website. So at the beginning of the pandemic, I created a guide for the public with easy to understand pragmatic information about the SARS-CoV-2 pandemic. The idea was make it simple and make it actionable to help reduce depression and despondency regarding the pandemic. I don't advertise on it. I don't make any money off of it. I also have videos for the public, for the medical community, on my YouTube channel, which is The Relaxing Sounds of Infection. So if you go to YouTube and you type in The Relaxing Sounds of Infection, you'll find my channel. And there's info, there's comedy, all sorts of good stuff. All right, exactly 1 hour.
You did great, Dr. Ketterer. And as expected with the material that you presented, we have some excellent questions that I'm hoping that you'd have a few minutes to answer for our audience.
Yes, I can answer the one. Yeah, go for it.
I don't, if you'd rather see the screen, or I can read it to you.
I can see it.
Perfect. So the first one about the reports about 30 deaths in Norway in a nursing home who received the Pfizer vaccine. What are your thoughts about that? And how can we convince people who might give you this as a reason that they don't want to get vaccinated?
I don't see the same questions that you do. Okay, I see one question under question and answer.
Okay, so this is in our chat room.
Oh, okay. I actually am not familiar with that story. When did... so I'm not sure I can give a really good response to that question without knowing the background to it.
Okay.
Yeah, sorry guys. I'm looking at the question and answer. Is the vaccine
go ahead and answer
still
that
effective?
One
so is the vaccine still effective if someone gets the second dose greater than the designated time requirement of greater than 4 weeks, which is an excellent question. So yes, the answer is yes. So you want to ideally, and this is, I assume they're talking about the Moderna vaccine in this case, because that would be the 4 weeks later versus the Pfizer's 3. The immunological memory that's formed on the second dose, the sort of booster shot, that has a lot more wiggle room than going before the 4 weeks or before the 3 weeks with the Pfizer vaccine. So I see some data suggesting you can go 4 days before the second dose. So you can go as early as 17 days with the Pfizer vaccine or 24 days with the Moderna vaccine. But as far as after that duration, it's not really well known, but it's hypothesized you can actually go several weeks after that recommended window. Ideally, you want to do it on time though, because that is how it was performed in the studies, in the phase 3 studies. Are antibodies found in breast milk? Good question. I believe that is true, but I would need to research a little bit more into that.
Dr. Ketterer, we have another question here in the chat room.
Okay.
Do you think that we are going to have to get vaccinated annually for COVID due to the virus becoming mutated?
Right. So I kind of addressed that question in the actual talk, in that we're using essentially a unmodified pre-conformation spike protein, which has multiple different epitopes. I left this metaphor out because I didn't want to go out of time, but think of the ACE2 receptor into the cell as a lock, and the virus in its spike protein is the key. If you modify the key too much, it doesn't fit in the lock. So the receptor is a 3D, think of it as like a 3D lock. The key being the spike protein is a 3D key. And the way that the key interacts with the lock is through things like hydrogen bonds. And if you change too many of the amino acids, you lose the bonds that allow the binding of the spike protein to the ACE2 receptor. So at some point, if the virus mutates enough, it no longer works in the ACE2 receptor. This is the reason that they looked at the spike protein. Again, when people think that this is rushed, it's not. A lot of this research was based off of the spike protein from SARS-CoV-1, which has about a, don't quote me on this, is 70% sequence homology between SARS-CoV-1 and SARS-CoV-2 spike protein. But long story short, you change the key too much, in this case the spike protein, through mutations, it no longer has the ability to infect cells. So I think the vaccine, because of the fact that it's producing the completed full spike protein, will likely not be affected by variants. And because the virus mutates it not nearly as much as influenza does, these are small point mutations. That B117 variant has 4 point mutations, 4, which is not a whole lot.
All right, we've got another question. When would you recommend vaccination in those who've received one of the antibody products like Regeneron or BAM? I can't say the whole name.
Bamlanivimab.
Okay.
Bamlanivimab.
BAM.
So again, this is where I said it wasn't studied. So CDC has some guidance on this. If you look, there's the IDSA Real-Time Learning Network, which is an excellent resource for pharmacists and clinicians. That is one of the questions that they have up there. There is no definite time frame. So when I put up that slide that said, should you be vaccinated? I said yes, with the 3 caveats, which were, do you currently have SARS-CoV-2 infection? Do you currently have COVID-19? If you do, delay it till your symptoms are completed. So in the cases of folks who have gotten BAM or Regeneron, I would go ahead, if they no longer have symptoms of COVID-19, I would go ahead and vaccinate them.
All right, we have many clinical pharmacists for our group that work in the area of oncology. And so one was very curious about if for her patients that are receiving traditional chemotherapy, so not immunotherapy, is there a recommendation of when we should vaccinate that population, or can they not receive it altogether?
No, they should absolutely receive it. So as I talked about, they are some of the highest risk groups for severe COVID-19. If there was going to be a break in their chemotherapy, or if they're going through cycles and they're off cycle essentially, that's when I would vaccinate them. So it would be dependent on the PK of the chemotherapy agents that were used in the half-life. So when you reach that nadir of, for example, if you have a calcineurin inhibitor, if you're using tacrolimus, that likely will impact vaccine efficacy because you're not going to get T-cell proliferation. So if there is a period where someone is not receiving chemotherapy, that's when I would vaccinate them. So you can delay it if there was going to be a nadir. But if people are going to have a continuous state of immunosuppression, I would just go ahead and vaccinate them now.
Another question, do you recall what the guidelines are for patients who are receiving IVIG treatment as to when you should delay giving them the vaccine?
I haven't seen that specific question, nor have I seen IVIG as a contraindication. So those groups are likely going to have a reduced response to the vaccine. Groups that have acquired hypogammaglobulinemia will likely have a somewhat reduced response. But because of that, it's important that you vaccinate them ASAP.
We had one curious audience member. Do you know why they used the meningococcal vaccine in the AstraZeneca study?
Absolutely.
Okay.
So I think I mentioned it in the talk. they did that in the first dose. So it does a couple different things. One, it is a good way to compare side effects. So you're comparing a known active vaccine side effect to your vaccine side effect. So you can say, okay, so you get meningococcal vaccine, you also get arm pain, you can get fatigue, you can get fever. But they also wanted to compare sort of baseline immunological response to a vaccine. So that response to the meningococcal vaccine is something that's actually better than a placebo. You are getting activation of the innate immune system, for example, the immune system that isn't really responsible to a specific antigen. So you are getting immune activation from the meningococcal vaccine. So they wanted to actually make the comparison, the placebo group, harder for their vaccine as a way to stand out and differentiate themselves.
I guess, is there a reason why it wasn't like pneumococcal versus meningococcal? They just gave a vaccine.
It could have been pneumococcal.
Okay.
Yeah, absolutely. Part of the reason maybe, actually there is a little bit of logic to meningococcal vaccine over pneumococcal. And now I didn't read this as the reason why they chose it, but fewer people would have gotten meningococcal vaccine than pneumococcal vaccine. So the initial immune response to the vaccine would likely be more broad.
All right, we had one audience member that wanted to ask about the recommendation of zinc for 14 days and vitamin C, because at their institution, it is ordered on all of their positive patients.
I'm going to go back to that slide where I talked about you all should stand up to people who are using zinc and vitamin C and vitamin D and ivermectin, i.e. the FLAC group who's pushing this when there's absolutely no data that shows that this is effective in a randomized control trial. So this is where you stand up. As an ID clinician, I DC these things, as you would if someone was on hydroxychloroquine.
We had another, would it be a good idea to use an alternate arm for the second dose to distribute the arm pain better? Or does it change, or could it change the efficacy?
It wouldn't change the efficacy, but I'm going to give you, I had the vaccine pro tip, which is vaccinate, if you're a side sleeper, vaccinate on the opposite side that you sleep on. So in my case, I sleep on my right side, so I vaccinated my left arm or left shoulder, left deltoid, so that when I sleep on that side, it doesn't hurt. I'm also right-handed, so typically I get vaccinated on the opposite or whatever side you don't sleep on.
We did have a question about, do you know of any other DNA vaccines out there?
So I didn't talk about all the vaccines that are currently being developed because there's, I believe, over 80. And I didn't talk, there are other DNA vaccines. There's replicating DNA vaccines. I didn't want to get into it. And there's attenuated virus vaccines that are coming. I talked about the ones that were the furthest along. And I talked about Janssen because of the fact that they're going for a single dose vaccine, although their data on single dose is not out yet as far as the efficacy goes.
All right, and then although not directly related to this specific vaccine talk, we did have an audience member ask if you knew of any new treatments for hospitalized patients besides dexamethasone, remdesivir, that we're all using.
So I have a second talk, grand rounds that I gave back in December on my YouTube channel, The Relaxing Signs of Infection. If you go on there, you can see it has some similarities to this talk, but the first half of the talk is entirely on therapies. And the sort of net of that discussion is, other than dexamethasone, for patients that are oxygen requiring, none of the other treatments really have great efficacy, and remdesivir is in there, in that group that the efficacy is sort of questionable, whereas the US trials showed some reduction in symptoms, symptom duration, but not actual changes in mortality. And then the larger WHO trial showed no effect to remdesivir whatsoever. So in my talk, I do take a bit of a position on remdesivir. If you're going to use remdesivir, I would use it immediately after someone has symptoms. So a lot of these medications, convalescent plasma being one of them, remdesivir likely another, the efficacy of it is really in that first day 2 or 3 after someone has symptoms, when the virus is really actively replicating. After that, the efficacy of those treatments drops substantially. So, you know, my position is remdesivir may not have much of utility, and the other treatments, the monoclonal antibodies, possibly in people that are, so where they were looking at monoclonals are people that were likely to progress to severe COVID. So the studies that were done, which were a lot fewer number of participants, and it's in the grand rounds, we're looking at particularly at patients that were likely to progress to severe COVID, and the people who got monoclonal antibodies, they didn't. But what they were looking at, their primary endpoint was antibody levels. And this is important. We still don't know the amount of neutralizing antibody that is necessary to prevent infection, like we do with hepatitis B, for example. So when I talked about NSAIDs and acetaminophen blunting the immune response, but you still have a lot of antibody production, you know, is it enough to actually cause an infection if you are exposed to the virus, if you do take NSAIDs or acetaminophen? And the same kind of goes with bamlanivimab and Regeneron. You know, is the antibodies that you get additionally from these medications over what you already are going to produce actually change the clinical outcomes? And I think that's still a little bit up in the air. And that's why we have to vaccinate. We don't have great treatments for this virus.
All right. Hey, thank you so much, Dr. Ketterer, for an excellent and really timely presentation. And we really appreciate you staying on and answering all of our questions as well.
You got it.
For our AIP members, the handout is posted on our AIP website. And I guess thanks again, and everyone have a great night. We'll see you in February, and make sure you go and get your vaccine. Thank you so much.
Bye, everybody. It was a pleasure.